Hi guys, welcome to Ask the Egg Whisperer. I'm super excited to be on tonight with you. Tonight will be my last show almost of 2020. I don't know if you guys have counted, but I've answered almost 700 of your questions since I started Ask the Egg Whisperer. And if you're like, how can I get her to answer one of my questions? Don't you worry, I'm going to keep doing this. You can go to asktheeggwhisperer.com, fill out the contact form, put in your name so that, or you can put up a made-up name, it doesn't matter, just so that when I read out your question, you know who it is, if it's you that asked the question when you come and watch the show. My producer, Paula, she'll send you an email letting you know that your question is going to be answered on that show. And then she'll also follow up with the link. So if you aren't watching live, because sometimes I don't go on right at 4 because I'm kind of busy taking care of patients here, and I still have more patients to take care of as soon as I'm done with this. So thank you guys for joining me today. Let's get started. But before I get started, I have to show you guys some fun things over here. My husband thought I'd love a sparkling egg for Christmas. Isn't that really sweet? But then he got me something else, and you guys are going to totally crack up over it. He got me this. And I was like, honey, that's not a sparkling egg. It looks like a blue ball. I don't think he was really thinking of that when he got it for me. But when I saw it, I was like, maybe this could be the symbol for Ball's method. And this is the symbol for sparklingeggs.com. I cracked myself up, clearly. So for those of you who don't know what sparkling eggs or what the heck I'm talking about, but that's the sparkle checklist. So you can literally go to sparklingeggs.com and it'll all be there. So those are all the things that you would want to know at each monitoring IVF visit. These are the things that I tell my patients, like the size of the follicles, the protocol, the plan, your pyramid. Is your doctor happy? Are you happy is what you ask. When the retrieval is going to be. Should you keep going? What does the lining look like? And what is your estrogen level? Okay, so now let's get started. Okay, this is Tatiana's question. Thanks to you, I found my doctor. Thank you for all you do. I was starting my transfer number 3 while waiting for my Receptiva and ERA results. Yesterday, I got a call and my Receptiva came back positive at 3.4. I had or still have endometriosis, and I had a laparoscopy back in 2019. I had it on the right ovary and was diagnosed stage 3 because of a cyst that I had. Well, the number being high still worries me. So because of that, we stopped the transfer and I'll be put on Lupron and Letrozole for 2 months. Still waiting on the ERA results. I'm glad that I didn't do the transfer, but should I worry because of the level? Also, would the Lupron Letrozole affect my eggs? My AMH is 1.6. If this transfer works, we're done. We have only 1 embryo left, but if it doesn't, we will go for another egg retrieval. I trust your opinion so much. I wish you lived in LA. Your positivity is so amazing. Thank you for taking the time to answer my question. Tatiana, it's a great question. This is what I would do if it were me. I want people to have lots of kids. I mean, that's what I do. I'm the love doctor, but not the love doctor, the kind of doctor you're thinking. I'm talking about like the love, like there's no greater love than being a parent to a child, literally. So my recommendation is do another cycle now. I mean, if your Receptiva score, the BCL6 score, is in that range, it's going to take a few months, at least 2 months to get it down with a Lupron the way your doctor is explaining to you, plus the transfer cycle. So that's a month. So now you're looking at 3. And if the transfer doesn't work, then you're going to have to prepare for a transfer. And then you're looking at probably doing another retrieval in like 5 months from now. So in a case like yours, I don't know how old you are, but I would say you won't regret doing another cycle now. And doing another cycle can grow more endometriosis. And that's sometimes where it comes from. I mean, you had the laparoscopy and then you're on all these medications for mock cycles, transfers, egg retrieval. And so that can certainly make it worse. So that's what I would suggest if you were a patient of mine. And the supplements that you can consider taking are the things I talk about all the time. But specific to the BCL6 being elevated, you might want to consider looking at your lifestyle, making sure it's as healthy as possible to reduce inflammation, look at your diet, follow a type of anti-inflammatory diet. That's the kind of stuff that I tell my patients. And then the supplement N-acetylcysteine has been shown to prevent the progression and cause regression of endometriosis. Isn't that fantastic? I couldn't believe it when someone told me that. It was an endometriosis expert that told me that. So that's what I tell my patients who have it. In fact, I need to write this down because I did a phone consult today with a patient. I forgot to tell her that, so I have to remind myself. So I have to write this down. See, that's what I do. You should see all the little notes that I have everywhere, like everywhere. I have this cool little notepad that someone made me. It says the Egg Whisperer, and at the bottom it says sparkle every day. That's a very good reminder, I must say. Okay, So next question is from Shadi. Shadi says, I love your energy. I'm 41. My AMH is 0.02. I failed 3 IUIs 3 years ago. I had a myomectomy for intramural fibroids 3 years ago, and I again had 3 intramural fibroids and a right ovarian cyst with no symptoms. Do they need to be removed? So let's start off with that question, Shadi. You have a few more, and these are all really great. So the answer is yes. If you have fibroids, well, I shouldn't say yes like that. Like, yes. I mean, what I should say is if there's any possible way that they're growing, I would say remove them, because pregnancy could make them grow as well, right? And then if you're pregnant and they're growing, it could impact the growth of a healthy baby and cause preterm labor, preterm delivery, and that would really suck. Okay, so that's one to think about. If they're super tiny, and I refer to little tiny polyps and fibroids, sorry, not polyps, but fibroids, like having freckles on your face. Like a freckle on your face doesn't affect the growth of a pregnancy in your uterus, so a little tiny intramural fibroid shouldn't either. But if you have symptoms, if they look like they're growing and could possibly push into the cavity, they need to find their home in a jar, not in your uterus. And if the cyst looks like it's large, it's causing you pain, or it could be endometriosis, you might want to consider removing it as well. So the next question you asked is, what do you feel about using your sister as an egg donor? And I would say, I think that's a great option. It's really hard though, depending on your sister's age, if she goes through this for you and it doesn't work, right? So that's really emotional. So this is how you approach your sister. You say this, hey, sister. Isn't that funny? And you say, if I needed a kidney, would you give me one? And then wait for her answer. And if she says, yeah, I'd give you a kidney, then you'd be like, okay, good. You're donating your eggs to me because I need my eggs. I need eggs because if I don't have them, I really can't see living this life without a pregnancy. And you're my sister and you share my genetics. Give me your eggs. But the reality is your sister might say, you know what, I don't feel comfortable with that, or she might be partnered and her partner might say, that's weird. And that's unfortunate that sometimes that happens, but it's the reality. So you have to be prepared for the answer. So the other way of doing it is tell your mom. This is what we do in my house. I call my mom and I say, this is what I need for my sister. And my mom will call my sister. So that's the other thing, Shadi, is call your mom to call your sister to then say to her, I need you to donate your eggs to Shadi. And then see what they say, and then make it like your mom's idea so that your relationship with your sister isn't compromised at all. But of course, if she says no, you're going to hate her forever. No, you probably won't, but you know what I mean. So these are things that I've worked through. I have a lot of sisters donating to sisters, but I also want to make sure it works. So I'm really picky. So I don't want to make the relationship strained. So we still do all the psych and the legal stuff, and we check fertility levels and make sure that your sister's levels are good. And then we also want to protect your sister from fertility issues. So sometimes we even freeze eggs for your sister as well as donate some for you. And that's my freeze and share program. So that would be something that you could tell your sister. You'll be like, look, I'll freeze some of your eggs for you in exchange for you donating some for me. And mom said you should do it. So the next question is the miscarriage rate higher with a low AMH even if you use eggs from a donor? And that's a really good question. The answer is no. You don't even need to have ovaries to have a healthy pregnancy. You just need a really beautiful, strong embryo that's going to implant and grow. That's where that's what medications are used for. So we use hormones, estrogen for a couple of weeks, and then estrogen and progesterone for one, usually about 3 weeks before your transfer date. And this is all well coordinated. We have all the recipes spelled out on calendars for you. And we do preconception labs, for example, and we check your infectious diseases. We look at your cavity before we transfer, but that's how we do it. Next question is, does the HSG need to be repeated for a recipient if you use a donor egg? It was normal 3 years ago. And the answer is, yeah. I mean, not the HSG part, the tube part for those of you guys who don't know what the HSG is, but we want to make sure that there isn't a new growth in your uterus. You mentioned, Shadi, that you have fibroids in the walls, but you might have a little fibroid inside the cavity. So we would still do some sort of HSG, SHG, SIS, all slang, not really slang, for checking your uterus for polyps, fibroids, scar tissue. The next question you asked, this is a good one. Do you recommend the COVID vaccine before starting the IVF process? And the answer is yes, I do. Because COVID complications when you're pregnant, big thumbs down. They go much higher. And so ideally, I really want all my patients to get the vaccine. If they agree, if they don't, I'll be like, just wrap yourself in that bubble wrap and don't go around anybody who looks like a human, smells like a human. Please don't go around smelling people right now. Talks like a human, walks like a human. There should be some sort of rhyme or song like that. And then as far as dose of CoQ10, there's a brand that I like. It's called NeoQ10 through Theralogics, and you can use the code TUSHY, all caps, in their website and get it. You can take 1 to 2 tablets per day. 125 milligrams of that version is equivalent to almost 700 milligrams of CoQ10. It's compounded with something called Vesisorb that makes it a lot stronger than just taking plain old CoQ10. So I recommend 300 to 600 milligrams of CoQ10 otherwise. Thank you, Shadi, for your questions. The next question is from Erin. Erin says, hi, Dr. Aimee. I'm 37. I've been trying for 2 years to get pregnant, my long-term partner, without any success. Because of where I live in Canada, I had to wait 1 year to see an OB/GYN for an initial fertility assessment. You guys, can you imagine 1 year to get your tushy checked? That's a long time. They did an HSG and found that one of my tubes was blocked, but they don't know why. Now they want to do a laparoscopy to see what the obstruction is. My question is there a less invasive way to find out what could be blocking my tube? Could a CT, MRI, or ultrasound not pick this up? It seems really invasive to have to go through something that is exploratory. What are some of the reasons my tubes could be blocked? I never had an STI. STI, for those of you guys who don't know, is sexually transmitted infection. The OB/GYN said, based on my menstrual cycle and symptoms, I likely have primary dysmenorrhea and possibly PCOS. Are these reasons for the blockage? Erin, I think if you have dysmenorrhea, which is fancy talk for painful periods, it could be that the tube is blocked because of endometriosis. Doing a laparoscopy might help because they might remove endometriosis, see what's going on with the tube, but you want to make sure, especially because it's taking forever for you to get the care that I think everyone should get a lot sooner. But you know what? I totally get it. Not everything is the same everywhere we go or everywhere in the world, and we need to deal with whatever resources we have. But doing a laparoscopy actually is not a bad idea, because if there is endometriosis, if you told your doctor that you have severe pain with your periods, that endometriosis could be removed, and that might improve your chances of a pregnancy that is naturally conceived, not in an IVF lab. However, if the fallopian tube looks dilated and there's something called a hydrosalpinx, talk to them now about removing it, because you don't want to then have them wake you up and be like, there's a hydrosalpinx and now you have to wait a year for us to remove it. So get all those feelings out about what is it going to feel like if you wake up and the tube is gone. But my thing is this, you're 37, 2 years of trying, do IVF, right? We know your diagnosis before treatment. And if you were here, a patient of mine, I would say, let's do this, Erin. Let's make some embryos, freeze them, do the laparoscopy, transfer, and live happily ever after. Does it work out that way every time? No, but a lot of times it does. So given your young age and the amount of time that you've been trying, do all the tushy check, right? You've already done the tubes. It sounds like you've probably done the uterus. Make sure you've checked the sperm. It looks like you've checked, I can't tell if you've checked your AMH, but maybe you have because they told you might have PCOS. And PCOS in this situation could be a blessing because you hopefully have lots of eggs. So heal that PCOS. Make sure that you're looking at all the hope things that I talk about. Hope syndrome is what I call PCOS. And if you're like, what is she talking about? It's okay. You can imagine that I have a website to go with it, hopesyndrome.com, and look at all those things that I want people with PCOS to look at. So those are my recommendations for you, Erin. This next question is from Lauren. Lauren says, I've been going through recurrent pregnancy loss. And for those of you who don't know, that's actually why I went into fertility medicine, to help women with recurrent pregnancy loss. I think a lot of people don't realize that it is something that fertility doctors are specialists in. And I've been going through fertility testing to figure out a cause. We came up with a diagnosis of endometritis, and I went through a round of antibiotics. So there are essential lifestyle changes I should be making to lower my risk of yet another miscarriage. And could it really be as simple as a few weeks of antibiotics? So Lauren, I don't think so. And this is the reason why you would know that it could be just that easy. If your miscarriages were genetically normal and the pregnancy tissue was tested and you knew the chromosomes were normal, it's possible it could be from endometritis. Alternatively, it could be genetic viability of the embryo. And I have a workup. It's called the Angel workup. And it's the approach that I use. And that's the Angel method. And this approach will make sure that we don't miss anything else. And I bet because your doctor went so far as doing a biopsy for endometritis, you probably had these tests. You've probably done the autoimmune tests looking at antiphospholipid antibody syndrome. You've probably had the AMH test to make sure that it's not related to egg viability. You've probably had an anatomic evaluation looking at your uterus to make sure there isn't a uterine septum. You've probably looked at your nutrition. You've probably looked at genetic stuff like a chromosome analysis for you and your partner. You've probably ruled out diabetes and also thyroid issues. And you've probably looked at your lifestyle, looking at your body size to make sure that you're as healthy as possible. So those are the kinds of things that I think about as well. And then also look at your age, the number of kids that you want, and make sure that you've saved the eggs. and maybe even think about saving some embryos as well. So I hope that helps. This next question is for Carla, from Carla. Carla said, actually, before I do that, I'm going to take a drink here of my Dr. Aimee at Your Cervix mug. I get lots of fun things. Sparkly eggs, I got sparkly balls. Okay, Carla said, hi, Dr. Aimee. Thank you for answering my question. I'm 36 with a history of miscarriage at 9 weeks and 1 biochemical pregnancy naturally. I recently had a biochemical with my FET with a genetically normal embryo. I had a good lining. Hysteroscopy showed 3 small polyps, a normal HSG, and an ERA test. I also had the autoimmune protocol that included intralipid prednisone, Lovenox-Claritin, and Pepcid. Also, all normal labs and no major medical problems, no endometriosis or endometritis. What do you recommend for my second FET? Is it just bad luck? Why can't I sustain a pregnancy? Is it my uterus? Carla, I'm sorry you've been through all that. It's so hard because you feel like you've done IVF. This should save the day. You just test a number, you put it in, and it should work. And I've been here before with patients just like you, and it doesn't, and it's heartbreaking. And I know that there's special interactions that need to happen between the uterus and the embryo, and they have to be perfect, and a lot of it is still genetic. We just don't have the answers. I know from a scientific standpoint and in studies that I've read, I know what the answers are, but we don't have a test that I can do to show you, this is the answer. So until then, we just have to keep trying and seeing what will work, which embryo will fit right in. So I don't know how many genetically normal embryos you have left, but I would suggest maybe doing more cycles so that you have more embryos preserved, especially given your young age of 36. The other thing that I would have you consider doing is the receptiva test. I see that you've done the HSG and ERA. You've done a hysteroscopy, but I don't see that you've ruled out silent endometriosis. So that's one thing that I think could be really helpful in a case like yours. It is bad luck. Of course it is. But at the same time, there is still a lot of hope here. The fact that you've had 3 pregnancies just tells me, and it looks like 9 weeks, 1 biochemical, and I'm not sure if you had another biochemical, but either way, I do think that there's still a chance for you to have a healthy implantation based on everything that you shared with me. So my gut is, if you haven't done the receptiva test already, do that. Do another IVF cycle first and perhaps build in the receptiva into your cycle. So you can do an egg retrieval, and then a week after the egg retrieval, you can do the biopsy so you get the information by the time your period starts so that you can create a really good plan for when you're ready to transfer to see if you should do treatment. Sometimes even there's no data from patient results that suggest that she had, let's say I've done the BCL6 test and the CERT1. So SRT1 is another test that you can do with the receptiva test. And let's say everything is negative and you still have this kind of history. One of the things to consider doing is just empirically do, for example, a month of Depo-Lupron with Femera every single day. That might help with receptivity in the lining. There's some theories as to why that could be helpful. So while it's kind of annoying, and kind of is just a huge understatement, because Depo-Lupron is super, super annoying because of all the side effects. No one enjoys that. I've never had a patient oh, that was fun. That was a really great month of my life. I really loved that. But as long as you know what to expect, you can totally get through it. If you didn't know what to expect, you're going to be miserable. But that's kind of what I'm thinking in a case like yours. Also, take CoQ10. If you aren't already, look at all your supplements, look at your lifestyle, your diet, make sure you've built a really nice fertility team around you. Make sure you have a good therapist, both one-on-one therapy as well as group therapy. I love fertilityrally.com. If you guys haven't followed Fertility Rally, they're a great resource, and my patients love the women who have started it, and they have weekly meetings, and I think it's a wonderful way to connect with other people. So that's what I would recommend doing. And then Carla, if you haven't gone through Angel Method, it sounds like you've done everything there. Look at it again. And then last but not least, the other thing to consider is asking your doctor if they've ruled out adenomyosis. Okay, great. This next question is from Faith, and Faith says, hi doctor, thank you for the joy and laughter you bring me during this infertility walk and for all the info you joyfully share. Thank you, Faith. That's very sweet. I'm 31, diagnosed with pituitary hypoplasia, so I don't produce any hormones. My FSH is 0.5, TSH 0.01, AMH is 1.8. My husband's sperm count is 73, motility 55, morphology 3. Tried IUI twice, failed. Did my first IVF cycle, got 6 eggs, 2 mature, 4 immature on 225 Menopur, 1 Femera. 3 fertilized, transferred 2 on day 3, and the other one did not make it to day 5. The embryos were not tested. No pregnancy. I was on folic acid, quinone, and progesterone shots. Hormones are my only factor. Tissue check was done and completely normal. Is it possible to have good embryos of my own? Is it even possible to get pregnant? What can I do differently next cycle? Supplements, treatments, etc. you recommend? Faith, absolutely. First thing would be to take this one here, something like this, NAD. You can get it from this company, TrueNiagen.com. Actually, this reminds me that I should probably take mine. I don't think I've taken mine for today. And then the other thing to consider doing is HGH. And no, I do not take HGH, although I would love to, but I don't. So it'd be cool to see if I could live forever. The other supplement is this. It's called pterostilbene. So I like to take these together. And you're like, why is she taking them? Isn't her family complete? And the answer is yes, but I'm studying my own hormones over time. I'm 44, almost 45 in April, and I kind of want to see what my hormone levels will do as I'm taking these. And so far, it's been pretty interesting. And at some point, I'm going to share it with all of you guys as far as what my FSH, estradiol, and AMH levels have been trending over the past probably 8 to 9 years that I've been trending them. So you see how easy they are to take. There we go. So my husband, totally aside, he keeps teasing me that I'm not bringing the anti-aging stuff home to him. I'm like, honey, I have a really good life insurance policy on you. Why would I do that? I love you. He never watches. You'll know he's watching when you start seeing poop emojis in the comments. Okay, so back to Faith's question. So for you, Faith, what I'm thinking is take the supplements, add the HGH, and because you got too mature for immature, talk to your doctor about maybe pushing your follicles a little bit bigger. See how much of a trigger shot they gave you. Go up on the trigger shot. I've even used as much as 20,000 international units of HCG. It sounds scary. You're like, whoa, is there going to be an egg explosion? Or also known as an egg explosion. And the answer is, no, your eggs will not explode. They might be beautiful and sparkly and more mature, but they won't explode. Look at the timing of when you did the trigger shot to when they did the retrieval. I hear sometimes things like, oh, the clinic was running ahead of schedule, so they did my retrieval 2 hours early, and they called me in earlier. I'm like, huh? They did your retrieval at 34 hours, and you triggered at 36, and now you got only 2 mature eggs out of 6 eggs? Well, that would explain it. So don't do that next time, okay? So that's kind of what I'm thinking. And as far as chromosome testing and carrier screening, I would do that. So it sounds like you didn't do PGS testing on your embryos. That's okay. But make sure you don't need to do it. And what I mean by that is the only way you would need to do it is if you or your husband had a translocation or something like that. So you might want to find that out before you do another cycle. So I hope my little tips help. Okay, this next question is from Deirdre. Deirdre says, hi, Dr. Aimee. I'm 32 with stage 4 endometriosis, no kids, 2 surgeries for endometriomas, 4 retrievals, 3 failed transfers, 1 chemical pregnancy in the last 2 years. You guys, I just admire every single person who sends in these questions. And I hope for those of you who listen, you hear how resilient everyone is who reaches out to me and how strong they are. And that should hopefully make you realize that you're totally not alone. I wish I could have some egg whisper community where everyone could hang out and be friends. Because clearly anyone who sends me a question, you guys all have a lot in common. And you're all kind of badasses as far as I'm concerned. Last retrieval was the first time we did PGT testing on 4 embryos and none came back normal, which crushed me. The doctor suggested 1 last retrieval with PGT testing, which we are currently waiting results on. In his opinion, if we don't produce any normal embryos this time, he can't help me anymore. The protocol with 4 embryos is the best we had. We did 75 Menopur, 225 Follistim, and Lupron trigger. This last Hail Mary round, the doctor cranked up meds to see if we can get more eggs. 450 Follistim, 150 Menopur, and long Lupron protocol. We had less mature eggs, 6 out of 12. Every retrieval, I get 12 eggs and usually 10 mature, so clearly it didn't help. I'm at a loss for what route to take next. I know it's time to switch doctors, but is there something that can be done to help the chromosomal issue with my eggs? Done the supplements, etc. things. So Deirdre, I don't know if you've done the HGH, but I would definitely do that. So do HGH twice a week until your next stim start. Start HGH with your next stim start, and then maybe do it every day if it's not too cost prohibitive. The stuff is expensive, so don't get me wrong. From the standpoint of your dose of medications, I would see if you would consider doing more Menopur than Follistim. So rather than doing, let's say, 450 of Follistim and 150 of Menopur, do the opposite. Not that I want you to do 450 of Menopur, because Menopur is so expensive. It's ridiculously expensive in this in this United States. So maybe consider doing 300 of Menopur and 150 of Follistim. This might help with the embryo quality. The other thing that I would say is take N-acetylcysteine. It sounds like you've done all the supplement stuff with the NAD, but do continue to do that. Look at your body size, activity levels, do strength training, like build your muscle tone. I know you're like, what is that for? And I would say decreasing inflammation could help with egg quality. And it sounds like you're someone who's obviously like pretty darn tough, and like you're clearly not going to take his no for an answer, and you're going to keep going. So I would just continue to do what you can to find joy in each and every day. I know it's like annoying. There's like so much going on. You're like, does she not realize that there's a pandemic? And she's like telling people to find joy. Like, why can't we all be miserable together? Well, darn it, I have to tell you that I have a lot of stressed out people that I have to be strong for. So I have a framed picture in the front of my office that says, find joy in the journey. And I have to think of this phrase, like happy eggs, better quality eggs. I mean, I don't know, but I feel like if I'm here being like, I believe in you, I do feel that you're going to have a good egg left. You're only 32 years old. I will not accept that you don't. And if you want to keep going, you can. So there's something about that that's reassuring. And it helps you breathe a little bit. But at the end of the day, endometriosis is really bad. It hurts our eggs. And I think that just thinking in your mind, I'm going to be a mom one way or another, and then giving yourself time to kind of figure out what the next cycle should look like, and talk to not just one more doctor, maybe 2 or 3 more doctors before you do the next cycle. I think that would be really helpful. And last but not least, embryo diamonds. embryodiamonds.com, and look really closely at all your official reports. And this is for everyone out there who's listening. Find out the quality of your embryos, the implantation rate per embryo. But when someone tells you that all the embryos are abnormal, you have to be like, wait a minute, really? Did you guys look at mosaicism for me? To have 100% abnormal for someone who's 32 is really unusual. So if they haven't checked for mosaicism, trust me, they have checked. They're just not reporting it to you. So ask them that. Say, are any of my embryos mosaic? Can you prove to me that you actually have, done that reporting in a transparent and honest way with me? And I can tell you that mosaic embryos, especially low-grade mosaic embryos, have a good chance. And when I say good, it's not 0. It can be 40-50% chance of turning into a really healthy live birth. And come this April, I don't want to announce it too early, but Nova did a beautiful documentary following a family, and it's going to be on PBS this April of 2021 about this very issue. So I'm really excited for everyone to learn from that. So finding out if your embryos are mosaic, especially when you're 32 years old, when someone has told you that they're all abnormal and you need an egg donor, is exactly what I would do. So do a post-test consult with a genetic testing company, do a post-test consult with your doctor and embryologist, and just make sure you've learned everything. And those official reports will also tell you if you would benefit from extra technology in the IVF lab, like Zymo or Pixie. Those kinds of things are what I would be thinking about in your case. This next question is from Zara. Zara says, hi, Dr. Aimee. Thank you for this opportunity to ask you questions and for all that you do. I'm 33 and I've been trying for 3 years. In the first year, I had a miscarriage at 8 weeks. FSH was 6, TSH was 2.8, AMH was 0.8. The doctor recommended IUI, so I'm just starting cycle number 3. I get cysts every cycle. The question is this the right treatment for me? Is there anything I should be doing to increase my chances? My gut is not comfortable with this plan, but I'm just going with it because I don't want to waste any cycles due to low AMH. Thank you. So Zara, you're totally right to be uncomfortable with this. Listen to your gut. You've been trying for 3 years. You're 33 years old. # save the eggs. And since it sounds like you have a sperm source, my mom, as she gets older, she'll say things like, no one needs a man to have a baby. And I'm like, shh, stop saying that in front of my husband. Gotta love her. My point is this, free some embryos. You're 33 years old. It's already been 3 years. Just think about it this way. It's been so hard to get pregnant for baby number 1. Just imagine what it's going to be like when you're 35 or 36. We don't have another 3 years to spend doing IUIs. And fertility doesn't get better as we age. You can't stick Botox in your ovaries. I wish and you guys can tell that I clearly need Botox. I wish that I could be like, you guys, I invented the fountain of youth for our eggs, and no one needs to freeze eggs anymore, and no one needs an egg donor. But until then, like, God knows if that's ever going to happen, you need to save eggs. And that's what I would recommend doing, Zara. I would repeat your FSH estradiol. I would do all the genetic stuff. I would go through the Tushy method. I would basically get your diagnosis down like as much as you possibly can as to why it hasn't worked in the last 3 years. And that pregnancy that you had that miscarried at 8 weeks might have a lot of answers for us. That pregnancy is saying, please look at my chromosomes. Please do a carrier screen. Please do an autoimmune workup. Because once you get that normal, healthy embryo, we don't want it to result in another miscarriage. And I know part of being human is just having those experiences. But as much as we can control things that are in our control, which is very, very little, I know, at least we go into whatever you're going to do next with all the reassurances that you have listened to your gut. As a young person, especially someone who doesn't have kids, sometimes we're afraid to use our voice. We're afraid to advocate for ourselves. I find this really actually quite hilarious, where people will message me and they'll be like, I want to ask you this question because I don't want to insult my doctor. And I'm like, okay, you're the one that doesn't have kids. Your doctor does. Why would this be insulting to ask such a basic, simple question? Like, you don't need to insult them. Like, just advocate for yourself and say things like, I would like an HSG. I have a history of an ectopic and please do that for me. So just remember, for those of you guys who are watching and maybe for the first time, that the best patient is the most annoying patient, but not really annoying, but like you advocate for yourself and you don't say sorry and you just keep asking the right questions and listen to your gut. Again, so sorry, listen to your gut. If you don't feel comfortable with what's going on, listen to your gut and figure out why and do what feels right. Okay? This next question is from Rachel. Hi, Dr. Aimee. Thank you for being such a bright light to all of us. I'm 39. I'm going into my 7th egg retrieval in January. I currently have 3 fair or poor embryos on ice, and we're going to try and get a few more so we can transfer a few at a time. With a lot of trial and error, we've found so far that the best protocol for me is estrogen, letrozole, omnitrope prime, and stim, Gol 200 with HCG20 IUs. For those of you guys who don't know what HCG20 IUs is, you're probably like, why is she using HCG20 IUs? Because don't we use that for the trigger shot? And the answer is you can also use it and it mimics menopur as well. I've spent some time in Paris, so now I have a French accent. Some of you might know what that reference is to. I typically prime 30 days before with Omnitrope 6 units. Do you think I should continue to prime with it or just use a higher dose during stims? What is the difference? Does it help with quality the same? I've heard HGH can help, but I've also heard that it can really disrupt good egg quality. What more can I do to help improve egg quality? I already take CoQ10, vitamin D, inositol, turmeric, Ovavite. Anything else you think I should take? Thank you for being here for all of us. I appreciate your time, Rachel. Rachel, here's the thing. I don't think HGH can hurt your egg quality. I think it just hurts your wallet because it can be kind of expensive. I don't know why some people react better to it than others. I wish there was a test. I've heard people doing like IGF-1 levels, and then like if that level is low, then they're a good candidate. I'm like, I don't really know that that's the case, but that's one way of justifying or seeing if someone would benefit more than other people. But I've already talked about these supplements already, the NAD and the pterostilbene, and you might even consider higher doses of CoQ10. I do think that priming, at least 2 weeks or 30 days before your stim start could be helpful, and taking it every other day or every day during your stim could be helpful. But really look at how much you've really taken, and is it really going to help? Because that's a lot of money. I mean, anyone who knows how expensive HGH is knows that it's not cheap. I mean, one vial is almost $400, and that one vial, if you're priming, you just basically go through 2 vials at least a month, and then that's almost like $2,000 worth of a medication that might help, might not help. So if you really notice that it's helping you, I would say it could be worth it. But if you don't notice that it's helping you, then stop it. There is, I think, a long-term effect for some people that could be beneficial. As far as anything else you could take, I don't think so. But I would say look at the sperm and see what your sperm is taking. Like, make sure that he's also taking all the same things. He doesn't necessarily need to take like inositol, maybe if he's on the curvier side. But he could take CoQ10, vitamin D, a men's like fertility blend. That would be kind of cool for him to take. So Conception XR is the blend at Theralogics. And for those of you who don't know the PRC code that I tell people on the show, it's all caps Tushy. But that's, I know, surprise, right? Surprise. So that's kind of what I would look at. And look at the sperm quality again, and, not just look at the semen analysis, but maybe do with the number of cycles you've done, maybe look at sperm DNA fragmentation and ask your doctor, hey, can you throw in a Zymote fertility chip for me in my next cycle, or maybe add Pixie, just something different, something new. I mean, let me just show you guys for people who are watching. Let me see if I can find it here. This is what a Zymote chip looks like. You can see it right here. It's basically like a filter for sperm, and the best sperm win the race, basically. Okay, this next question is from Carrie. I'm 26 and I have PCOS. With my last retrieval, I had 40 follicles, but only got 15 eggs and 9 were mature. Is there a protocol that might result in more eggs, less follicles, or is this the case with most PCOS patients? So Carrie, let me tell you, there's something going on right now. It's called the pandemic, and no one wants to kill anybody. I know I'm saying that in a funny way, but it's not that funny. But the reality is no one wants a patient to get really sick right now from severe OHSS and go to the hospital. We are all, trust me, purposely understanding our patients, especially patients with PCOS, especially 26-year-olds with lots of eggs, because we want to keep you safe. The reality is 9 mature eggs for a 26-year-old, the viability is quite high. You probably have at least an 85% chance of having 1 healthy pregnancy, probably a 50% chance of having 2 from that number of eggs, 9 mature, at the age of 26. So, I mean, I totally get why people are, stimming patients in this way, and I think it's very well justified. But now that you've had this experience, you can say to the doctor, like, I was okay. I didn't have severe OHSS. So maybe next time, push you 1 more day using slightly higher dose of medications, maybe add a little bit more HCG to your trigger shot. All of those things can help. And for those of you who haven't heard my tips for a really good egg retrieval experience, these are also things that can prevent OHSS. So salty drinks. I should start my own brand of salty drinks. Basically G2 Propel, Gatorade, Powerade, stuff like that. You have those electrolyte powders like Drip Drop, plant-based or animal-based protein powders and shakes like whey protein. V8 works really well. So all of these things are really hydrating, things with lots of salt, I think keep people really safe going through this process. And it's too late to start that like after the egg retrieval. I mean, it's not too late. I mean, it's still a good idea to do after the egg retrieval, but I start my patients usually 4 days after their stim start, especially in young women with lots of eggs. And then I even add other medications like bromocriptine, Femara, even ganirelix after the egg retrieval can help prevent OHSS. And then I'm really careful about the amount of HCG and Lupron that I give patients. I've had 1 case of OHSS where I had to actually drain ascites from somebody in the last 13 years. And that was actually a Lupron trigger. So that was 1 case probably in the last 5 years from a Lupron trigger. And before we were really, using Lupron a whole lot, I actually have had at least maybe 3 cases where I had to go in and drain ascites, but no one hospitalized. Thank God. Okay, this next question is from Arun. Arun says, hi, best doc in the world. Arun, trust me, I'm not the best doc in the world, but I love what I do. I probably get the award for most passionate doctor and maybe for most hardworking. I get that award. I'm 32. I have PCOS. Retrieved eggs when I was 30. 3 losses so far. 1 biochemical, 2 miscarriages. PGT normal, never saw a heartbeat. Stopped growing after 5.5 weeks and lost at 6 and 7 weeks. Last miscarriage, we could test and it came back trisomy 15. So I removed a polyp, stage 1 endo before this last transfer, full thyroid panel, all in control, autoimmune check, karyotype check, ERA check, acupuncture check, Lovenox done, baby aspirin taken, prednisone, everything I can possibly think of done. I have 3 PGT tested embryos left. 2 that are 3BB, 1 that's a 5BB. I tested them after freezing, 1 decided to test after the chemical, and 3 day 7s untested left, 2 5BB, 1 6BA. So her questions are this. Do you think testing my embryos after freezing can contribute to me having these losses? So Arun, that's a really good question to ask your doctor in the embryology lab that they work with. So there's lots of QA/QC that goes on in an embryology lab, and they track this kind of stuff to see if the miscarriage rate is higher from embryos that are thawed, biopsied, and refrozen. In some cases, the answer is no, it's the same, just kind of depends on the quality on that report. So look at the refreeze report, right? So you have a freeze report, and then you have a thaw biopsy refreeze report, and you want to make sure that you have that newest report, because that newest report might be different than the original report. Do you think I should do another retrieval? And the answer is this. It depends on how many kids you want, and the thing is, it also depends on how many embryos you're getting per transfer. So I always make the decision as to whether we should do another cycle looking at your age and what your fertility is going to be like when you're ready to use another embryo. So if, let's say, we do a transfer and this next one doesn't work, then you're left with basically 2 good embryos, and those are the 2 that are not day 7. Day 7 embryos can be just fine, but sometimes we lower the implantation rate for day 7 embryos. So if in 2 years you might need to do another cycle, you would say, okay, you're 34 then. You had a bunch of eggs retrieved when you were 30. You should still have a whole bunch of eggs retrieved when you're 34. So that's kind of how I would think about it. I would say you probably may not need to do another retrieval right now unless this next transfer doesn't work. Are there any other tests we should do, especially after the trisomy 15? So given that your PGT tested embryos came back normal and you had this trisomy 15 pregnancy, I imagine that you don't have a translocation, that you and your husband don't carry an extra piece of a chromosome that caused the trisomy 15, and that was just, based on random error of cell division between the egg and sperm when that embryo was dividing. As far as changing the transfer protocol, it sounds like you've done everything, but I don't see a test for endometriosis. I don't see the receptiva test, and I don't see that you've looked at your fallopian tubes. So that's something that I think about in a case like this, especially when someone has had a biochemical pregnancy. So I would go ahead and look carefully at the anatomy of your uterus. I would do the receptiva test. I would look at the results and then apply the lessons from what you've learned so far as to what you're going to do next. And maybe even if the receptiva test is negative, or maybe if you just don't want to do it, pretend like it's positive and go ahead and do a course of Depo-Lupron with Fumarate and see if that would help. That's kind of the strategy that I would use in a case like yours. As far as a fresh transfer leading to more success, I would say a fresh transfer could, it's like fresh is just as good as frozen. Frozen is just as good as fresh, but frozen just gives you more information, and fresh could be better if your doctor thinks it's better. Right? That's a whole lot of what is she saying? But the reality is if your gut is you want to try it fresh, then I would do that. But there's something that's really important. You told me that you have stage 1 endometriosis. So it sounds like you've probably done a laparoscopy at some point. Otherwise, how would you know that it was stage 1? So maybe think that this could be related to adenomyosis or endometriosis, and maybe do some treatment around that and do another polyp check again before you do another transfer. As far as transferring more than one embryo, my general rule is that if I've transferred one embryo at a time and I don't have a healthy pregnancy, then my third transfer, I would say, can we please put 2 in, or at least talk about it and see how you feel? So the answer is yes. I would definitely consider 2 in a case like yours. That's my thought with that. Next question is from Rebecca. Rebecca says, hi, Dr. Aimee, you're literally amazing. Rebecca, are you sure you're not my mom? My sister would never say that. Maybe my mom would. I'm 41, doing IVF for 5 years. Rest assured, I've had all the tests and I take all the supplements you recommend. My diagnosis is recurrent implantation failure. And you guys all know I hate that word failure, so we're going to make it recurrent implantation issues. I've had 12 embryo transfers, 3 of which have been PGS tested. You guys, she's had 12. 12. That's a dozen. That's a lot. I've had 2 miscarriages, 1 trisomy 22, and the last most recent with PGS tested embryo that split into twins and had strong heartbeats but failed at about 8 to 9 weeks. For those of you guys who don't know that, that's a very high-risk pregnancy. The likelihood of a pregnancy that continuing is quite low. So the fact that it stopped growing isn't surprising. It isn't unusual for them to stop at around 8 weeks when they split like that. The products of conception were tested and they came back genetically normal. I'm being treated with the immune protocol, and here's what they put me on: Plaquenil, prednisone, Clexane, because of a ANA result. I recently did an ERA showing pre-receptive by 24 hours. I've transferred 2 embryos on day 6, now one of which were the twins, so we feel like we might be onto something, however. My question is regarding something you mentioned about HLA-KR or KER interaction. What exactly should I ask my doctor to check for if this is a factor for all our failures? I've had the NK biopsy, but result was present, but on the lower side. So this is a great situation, Rebecca, for you to do that test. But let me tell you something else. I actually discovered the receptiva test from a patient who had done not 1, not 6, not 10, not 12, 18 transfers. She brought the test to me, and she's like, Dr. Aimee, you don't know me, but now you're going to know me, and let me tell you. Everyone else thinks I should use a gestational carrier, but I don't think so. There's something about this test. I want you to do it for me. And then I did it, and I was like, I don't know what to do with the results. And then she told me, well, this is what you should do. And then I talked to the company. I was like, okay. And 1 month of Depo-Lupron later, live birth. Transfer, it worked. So that is something that you might want to consider doing. Some of your issues might be embryo quality. It could be sperm DNA fragmentation, so definitely look at all of that. But at the end of the day, if you haven't looked at the most obvious things like endometriosis, that's one place I would go. As far as the HLA-KER interaction, you just do the HLA testing on you and your husband and the KER testing on you. And it's basically like taking 3 puzzle pieces and seeing how they fit And then basically there's a chart that you look at that tells you what your HLA status is, what the Kerr status is, and what all the different combinations could be. And then you'll see if you need to switch out one of the egg source, sperm source to give you the highest chance of pregnancy for the KIR source, which is uterus, or you have the KIR situation that needs to be switched out. And if you moved in, let's say, a different KIR type, then your embryos will be like, voila, finally. Sometimes people just fall in love with the wrong HLA type. Or you just fall in love with the wrong matched KIR type. I mean, I used to have patients tell me when I started my practice way back when, 2008, literally, June 23rd, 2008. Not that I'm counting, one of the greatest days ever. They used to say to me, Dr. Aimee, I feel like I'm genetically incompatible with my husband. Like, that's why things aren't working. And I'm looking at them like, there's no such thing. Because that's like what we're taught. Like, the body does something when an embryo, gets near the uterus, so that there's no such thing as like incompatibility, that the embryo like knows what to do and it knows how to implant. And now we're learning, you guys, there's totally such a thing. And in cases where you've done 12 embryo transfers and you've had situations like that, this is when you're like, it's time to think outside of the box and look at this stuff. And so it's a simple blood test for both you and your husband. And then if it looks like there is some sort of incompatibility, that's the word that I use, around that, then you would then say, we need to make sure that we find a surrogate, for example, that is compatible. So you don't just pick any surrogate, you actually start doing the test on a number of surrogates, and it can get a little bit frustrating because you might not find the right surrogate, and it might take like 4 to 6 months to find the surrogate that has the right genetic match with you. But once you do find it, it's very satisfying because the chances of an implantation working go up so much more in my experience. Thank you for letting me talk about that, Rebecca. That was great. Okay, this next question is from Samantha. And Samantha says, hi, Dr. Aimee. I'm 38 years old, diagnosed with Graves' disease, and I have a low AMH. We have no male factor. I'm being treated for Graves' disease now, and my TSH is now in the normal range. My first retrieval resulted in 10 eggs retrieved, 9 mature, 5 fertilized with ICSI, and 3 made it to blastocyst, but all came back PGTA abnormal. 1 was a 40% mosaic. I'm preparing for my second retrieval. What would you recommend we try to improve our chances of getting genetically normal blastocysts the next round? I'll be priming with androgel. I'm on ubiquinol, NAC, pycnogenol, and prenatal. Thanks so much. Okay, Samantha, I would just also make sure that you're taking maybe fish oil if it's not in your prenatal, and extra vitamin D if you're vitamin D deficient. I did a really cool cure talks with Dr. Christine Marin, and she basically outlined like the best way to eat if you have thyroid disease. So I would look at that Cure Talks show. It was really, really informative. And then the other thing, stuff that I always talk about is maybe going up on your ubiquinol, adding the NAD, adding the pterostilbene. If you haven't added acupuncture, for example, maybe try and add that. And then if you didn't add HGH, maybe add HGH this next time. Even if you don't have male factor, maybe just throw it in Zymote. I mean, you can also do a sperm DNA fragmentation test, but even if like Zymote decreases the sperm DNA fragmentation from like 15, which is still considered normal, down to 6, I still feel like that could be something that's helpful, right? I mean, we're going through so much as women, with the shots and the surgery and the blood draws. Like, how hard is it to just like give the sperm a little bit, find a little more stringent way of picking out the best sperm cells to inject into each egg. So that's what I would suggest. See what your doctor thinks. Okay, this next question is from Sarah. And Sarah says, hi, Dr. Aimee. I just turned 34. I was recently diagnosed with lean PCOS. I have a high testosterone of 50 and a high AMH of 9.6. Prolactin and LH normal. I've been off birth control since September 2019 and hyper-focused on trying to conceive naturally since April without any luck. My partner and I both already eat Mediterranean style and exercise regularly. My cycle length is 28 to 30 days for the past 5 months, but I've been ovulating closer to day 20 to 22. We're scheduled to see an REI in February. We're planning to continue trying until then, but plot twist. Dun, dun, dun. Here we go, guys. I work at a hospital and I'm being offered the COVID vaccine. Should I take it? Should we stop trying to conceive until after I receive the second dose? Have you looked into the research about its safety in women trying to get pregnant or are already pregnant? I know they have not been included in clinical trials as of yet. Any thoughts or recommendations on my situation in general would be greatly appreciated. We're hoping for 2 kids. So Sarah, first things first, get the vaccine. Get the vaccine. That's what I would do if it were me, especially if you're exposed to COVID patients. It sounds like you are. You work in a hospital. That's what I would do. Okay. The next thing, heal your PCOS. Get your testosterone lower. There are lots of natural ways of doing it. The natural ways are taking supplements like N-acetylcysteine, lipoic acid, Ovasitol. And then the other way of doing it, especially if I don't know what your free testosterone is, but let's get that checked out. The other way of doing it is just getting on birth control pills. I know you're like, what? Did I not just tell her that I'm trying to get pregnant? But birth control pills is a really easy, quick way of bringing down your testosterone levels. And then you can also take a little bit of spironolactone, like 25 milligrams per day. And I can't guarantee anything, but I can guarantee this, that your testosterone level will be totally normal, I estimate, in 30 days or less. And then you'll stop everything. And then it'll be like magic. I predict that you might have a healthier ovulation and a healthier luteal phase. That's my prediction. But also ask your doctor to see if they would support you taking progesterone in the luteal phase. So 3 days after ovulation, take it about 14 days after your peak, and then check for pregnancy. If your pregnancy test is positive, continue it. So those are the suggestions I would have for you. So I am not concerned about the COVID vaccine if you happen to already be pregnant. I would like my patients right now to wait until they get past 10 weeks of pregnancy. But if you truly are frontline dealing with COVID patients right there face to face, I think the risk of getting COVID is far greater than any type of fever or reaction that you would get from the vaccine. Same with patients who are trying to conceive. I am saying to people, look, get the vaccine and then let's do a transfer, maybe 7 days, or let's time it so that your IUI cycle or your whatever it is that we're doing is about a week after your second dose. Again, because I don't want you to have a reaction and then be pregnant or be going through something that's really physically involved, like an egg retrieval, where you need to be like as strong as possible and be sleeping really well. But if you have a lot of pain in your arm, for example, that's keeping you up all night. Oh wait, that was me. I luckily have received the vaccine, and I'll just tell you, it hurt and I'm a very tough person. It didn't feel good. But lots of Motrin later, I feel a lot better. This next question is from Diana, and Diana says, "Hi, Dr. Aimee. Thank you so much for all your fertility knowledge. I'm 34 with diminished ovarian reserve per my doctor." Guys, at 37, that's kind of the norm, right? Like, it's hard to find a good egg at 37. It gets a lot harder at 40. It's almost impossible above the age of 42. But at 37, having an AMH of 0.7, which is what Diana says, I would say that's pretty normal. I don't call that diminished. I would say that's pretty good for someone who's 37. I've had everything from failed implantation to miscarriages. My question is this: I just had my 6th retrieval this week, and my doctor informed me I ovulated prior to the retrieval. I was devastated, especially since I had 7 beautiful follicles. I was told this just happens and rarely. Please, what questions should I ask? What can be done to prevent this from happening again? The meds I was taking were the following: 225 of Gonal, 100 of Clomid, then Cetrotide was added in around day 4 or day 5. Thank you in advance. Diana, this happens, and it's happened to me before too. I mean, I try and time things so perfectly, and I do things sometimes that other people don't do, and I do it because I don't want to stay up at night worrying, and I still do, worrying that someone's going to ovulate on me. And some of the things I do would be take Cetrotide the night of the trigger shot, right? So the night that you took the Novril or the HCG, did you take Cetrotide? Yes or no? That's one thing that you can do. The next thing is look at the timing of your trigger shot to when the retrieval was done. Was it done at 37 hours or 38 hours? Well, make sure next time maybe you're triggered at 35 hours. That could possibly prevent ovulation. Not only that, look at your progesterone levels and maybe even LH levels. When you do the trigger shot, maybe even the next day, do another Cetrotide as well. So those are all the little few tricks that I've done with other people who've been in this case. And I've had patients I have a patient once, I'll never forget her. We still talk because she made me work really, really hard. Before she even met me, she did 3 IVF cycles and she ovulated every single time on her doctor. So I did all sorts of stuff. I even did Lupron in the luteal phase and Ganirelix, which is just like Cetrotide. And I was even doing it twice a day to get her to a retrieval. And you know what she did on me? She still tried to ovulate on me. I could actually see the follicles collapsing, but I got her a golden egg. I think her golden egg is now 6 years old. Okay, this next question is from Ashley. Ashley says, "Hi, I'm a 39-year-old with endometriosis who just completed an egg freezing cycle. I was prescribed 5 milligrams of letrozole, Follistim 150, and Menopur 75. My trigger was 3,000 IUs of ACG Novorel and 0.8 mLs of Lupron at night, followed by Lupron 0.8 mLs the next morning. 15 eggs were retrieved, but only 8 were mature, 7 immediately and 1 day later. 12 days after the retrieval, second day of my cycle, my levels were AFC of 18, AMH of 2.4, estrogen 29, FSH 5, LH 7. My question is this: do you consider 8 out of 15 a good result, or should we consider not doing mild stimulation next time? So when I look at the stimulation that you did, it is mild. So a mild stimulation that gives you 8 mature eggs, that's pretty awesome. That's great. That's kind of what you would expect. That's actually probably more than your doctor would expect with that kind of stimulation, and that's really good. Is it bad that the LH is higher than the FSH? It isn't bad. That's typically what you would see if someone has, for example, more of a PCOS type picture, but an LH of 7 versus an FSH of 5 does not describe PCOS. Do you think the right trigger combo was used? Yeah, I mean, what you're sharing here is you were pretty uncomfortable for a while after, so your doctor said she might not use HC again, but I'm afraid the eggs won't get mature enough without it. Well, then you should say to yourself, is it worth it for me to tough it out and get the same number of mature eggs or more, or should I be okay with less mature eggs? So just see how you feel. And if you feel like you want to tough it out again and you're not too traumatized or won't have PTSD, then do that. Next question is, how many mature eggs should I be getting with these numbers? Thank you so much. So if you did a full stim with a follicle count of 18, you might be able to get 15 mature eggs. However, it sounds like you were really uncomfortable with just even 8 mature eggs, 15 eggs retrieved. So just imagine that the eggs would have to be a little bit bigger, so that might be very uncomfortable for you. So doing maybe another stim cycle with the same approach might be better than being more aggressive, to make sure that you're always safe. That's kind of like my thing, especially with COVID, is making sure patients are comfortable and safe and have a really smooth physical recovery after their egg freezing. And so you might want to say look, I did a great job. I got 8 mature eggs. I had a low dose stim. Do the same thing again. This next question is from Sarah. Sarah says, hi, Dr. Aimee. I've heard you mention taking whey protein. Can you clarify when you recommend this and why? What does it do? I enjoy whey smoothies daily just in general, so I'm curious if it does anything. I'm going to be starting IUI with donor sperm. Thank you. So Sarah, it helps you stay hydrated. It's nourishing. It also helps prevent OHSS, especially severe OHSS. And that's why I use it in women who are undergoing IVF or egg freezing with me, as it can help prevent this complication. And you usually start it, I tell patients to start it maybe a few days before their trigger shot, and they start going up on the dose up to even 60 to 80 grams per day, and then even continue it after the egg retrieval until they're feeling better. The next question you asked is this: I'm confused why my estrogen is still low. I've had blood work done for many months in a row, and all my levels look good, except my estrogen is still in the low 100s. TSH 0.9, prolactin 4, FSH 7, I have 11 follicles. We're trying letrozole for 5 days, and hopefully that helps, but why would my estrogen be so low and not spiking when everything else looks so good? I had HA for years and I've gained over 15 pounds, lots of cervical mucus, but still no period. I assume it's because of the estrogen. I don't understand why this is still low. So I'm just a little bit confused, Sarah, by you saying that your estrogen is low and it's in the 100s. So that's actually quite normal. It's normal around ovulation. So, I'm thinking with 11 follicles, I'm not sure that the diagnosis is necessarily HA. Here's what I would suggest. I would suggest this. I actually don't know how old you are, but I'd love to know. I'm trying to see if I missed it, and I don't see it here. Maybe you're watching right now live. Sarah, are you watching live and you can tell me how old you are? I don't think so. That's okay. So in someone who has 11 eggs, I don't know how old you are, but I would say get your AMH level checked. Use it as a baseline. If your FSH is 7 and your estradiol is 100, that suggests that your estrogen is suppressing and telling your brain to, shh, be quiet. I'm already making estrogen. Stop trying to stimulate me. And that might be a sign of lower egg quality. I'd want you to know that now. And I want your doctor maybe to be more aggressive with the ovulation induction, because Femera or letrozole for 5 days might not be enough. So especially if you want 2 kids, you might want to consider being more aggressive or saving eggs or doing IVF and creating embryos to give yourself the best chance ever. Okay, next question is from Kate. Kate says, hi, Dr. Aimee. My husband and I have been trying for 3 years and found out about a year ago my husband has very little sperm, under 100,000. Our doctor recommended IVF with ICSI. My husband keeps saying that he wants to get checked out himself because we all know right now he has a low T, but every time he has an appointment, he misses it. This is so hard because he says he wants to do this, but then isn't doing the steps to get there. I don't know if we should just move forward without knowing what is happening with him or continue to wait for him to get it together. I'm 36 and he's 43. Kate, don't wait. I've been waiting to say that this whole time. No, I just saw that your name is Kate. Kate, don't wait. Seriously, get your eggs frozen because something's going on. If he's not going in for his testosterone level, it could be because his testosterone's really high and maybe he's doing testosterone shots and he's hiding it from you. I'm just being suspicious and paranoid because let me tell you, Kate, I have seen it all. There isn't anything that I haven't seen before. And this is something that I see probably around 2 to 3 times a year where your guy is doing testosterone, not telling you, and he doesn't want to be found out. And that's the reason why the sperm count is low. So he's trying to go under the radar. And let me tell you this, you don't want to go through an IVF cycle and have it not work and then put yourself through all of that to find out that his testosterone was ruining your chances. And I promise you that you will be so pissed off and so angry. So ask him, just be like upfront, be like, dude, why aren't you getting your testosterone checked? Are you injecting yourself with testosterone? Is there something we need to talk about? Do we need to go to therapy? Do you need to talk to Dr. Aimee? Because I think it might be time to go to ballsmethod.com, send him the link and see what he says. Or get him just this gift of the blue ball. It's the blue testicle gift that my husband got me, thinking that it looked like an egg. But then he got me the other cute one. For those of you who didn't watch from the beginning of the show, this beautiful sparkling egg. This is kind of fabulous here, right here. So that's my recommendation. And for him, he should do all the tests, Y chromosome microdeletion, chromosome analysis. If you already know his testosterone is low, it could be, if you already know his sperm count is low, it could be from a high testosterone because he's taking testosterone, but it also could be from a low testosterone, and that could be fixed very easily by having him take Clomid, Arimidex, drugs like that, like HCG shots, Gonal-F. So those are the things that I think about. Also look at a varicocele. Have him see a male fertility specialist to get his balls checked to look for that dilated vein that can cause a low sperm count. Okay. This next question is from Sarah. Sarah says, are all the IG lives turned into podcasts and the same ones turned to YouTube videos? I mainly listen to the podcast. I want to make sure I don't miss anything. Sarah, the answer is yes. Paula does an amazing job. She's been my producer. We're actually friends for I think 35 years to be exact. So we went to middle school, high school, and we've known each other forever. So she's my producer and she does all of this for me, and God bless Paula. I'm so lucky to have her in my life so that I can just come on here, do what I do, and then she takes it from there and she makes sure that everything is on all the channels. This last question that I'm going to read to you today before I get to your live chatted questions is from, and she titles herself Grieving Lady. Here we go. I'm 38, no known infertility, doing this because my husband had a vasectomy. I got 4 good quality blastocysts out of 36 eggs retrieved in my first retrieval. 3 of them were normal. I decided to transport my embryos to a different clinic because I was unhappy with my doctor. My embryos were destroyed during the transport. After being accidentally taken by a courier to the wrong clinic, opened and mishandled. On the day of the frozen embryo transfer, 2 of the 5 BBs were 90% dead. The 6th BB was 40% dead, which was the lab's cutoff for transfer. I did not get pregnant. Would you consider this a failed transfer in your future decision making? From what I read, there was basically a 0% chance of pregnancy with 40% blast loss of cell loss. Assuming I make more embryos, should I do ERA, receptiva, etc.? Can I pretend it didn't happen? So, grieving lady, this is the thing. You've been through so much already. I would say, number one, these transfers don't count literally. Because you basically did a compassionate transfer, and it's always nice to be hopeful that it's going to work, but you're right. If more than 50% of the embryo didn't survive, and it sounds like 60% didn't, then the likelihood of an embryo implanting and growing and turning into a healthy pregnancy is going to be really low. If you do, I'm not going to say if you do, I'm going to say when you make more embryos, I would say, I would probably say let's do an ERA and receptiva because it would be so heartbreaking for you to go through another transfer that didn't work. And I would say this next time I would do everything you possibly can so that you don't learn lessons the hard way or the long way. It's not the hard way. It's just the patient told me last week, she said to me, Aimee, you can't learn everything at once. And that's true. You can't. So sometimes you have to transfer to then say, oh, maybe we should do this ERA receptiva test next. But in your case, I would say do the test. And for those of you who don't know what the egg whisperer diet is, that's my strategy of IVF. And it's something that I talk to everyone about. It's not something that everybody does, but it's something that I teach people. It's diagnosis, do your IVF cycle, endometrial testing or preparation or embryo transfer preparation. And that's when we do the mock cycle, which would be the ERA and receptiva. And the T is transfer. Okay, guys, let's go to your live chatted questions. My stomach is not grumbling yet, but it's going to be soon. So until then, I'm going to answer your questions here. So let's do this. What's the use of Medrol and Doxy before a frozen embryo transfer? So Medrol reduces inflammation and doxycycline treats any endometritis. Next question is, hi, is there a difference between using an egg donor who's 29 versus 21 or 22 years old? Not sure if when selecting egg donors, going younger is better. And the answer is it may not be better. Typically, I would say, if you have a 29-year-old egg donor, you might have more viable eggs more viable eggs in a 21-year-old donor than a 29, but I would say the most important thing is loving that egg donor that you've picked and feeling a really strong connection with her and feel like, yes, I would like this DNA. Because the decision about which egg donor to use has implications for your generation, the next generations to come. And so I wouldn't necessarily pick based on 29 versus 21. I would pick based on physical characteristics, things that you feel you have in common with the donor, and things that really get you excited about using her. And for those of you who are like, what is she talking about? How can you get excited about an egg donor? It's not your DNA. Believe me, when you're excited about using an egg donor, you know exactly what I'm talking about. Exactly. Because you know it, it's in your gut. You're like, this is the one. And so if you're can't figure it out between the 21 and 29-year-old, maybe you haven't found the right one yet. That's kind of how I would think about that. Next question is, hi, Dr. A, 6 weeks and a half. 6 weeks, and I have 2 episodes of mild bleeding, spotting with cramping, but always cramping these days. Spotting lasts about an hour and doesn't fill a pad. Having an ultrasound tomorrow. Okay, got it. So super common to spot in pregnancy, especially IVF pregnancies for whatever reason. Actually probably in all pregnancies, but there's something called a subchorionic hematoma that is, or hematomato. I like to make things not sound as scary because hematoma or hemorrhage sounds like really, really scary, but they're actually quite common and they don't cause you to miscarry, especially if they're small. But when I have a patient who has spotting in early pregnancy, I always say this, rest and relax. Let's see what progesterone you're taking. Let's see if we can increase it until I get to see you. Please stop all blood thinners, including aspirin. And I put a lot of patients on Lovenox, maybe 10% actually. Not a lot, but enough. So I'll stop the blood thinners and then have you come in right away and check your progesterone level and just do everything possible. And then make sure you're not lifting a finger around the house if possible, that you're just opening your mouth for your loved one to drop in peeled grapes. For at least 2 to 3 days, or at least the spotting has stopped, and avoid and have pelvic rest, meaning no sex. So next question is this: have you seen an IUI work at the age of 42? What are the chances of success with IUI if IVF hasn't worked? And the answer is yes. I've had patients who've done IVF and it's okay, been there, done that. That didn't work for us. And then you're taking a step back and it feels like it psychologically. You're I don't understand. IVF didn't work. I got no normal embryos. Why would IUI work now? And the answer is because you never know when you're going to ovulate a golden egg. And as long as you have a reasonable number of eggs, and for me, reasonable would be 2 to 3 at the age of 42, there is still a chance. But if your FSH level, let's say, is in the 30s, then at that point, you might want to rethink what you're doing and talk about other options. Next question is this: hi, Dr. Aimee, I'm 18 days post 5-day transfer. I had a frozen transfer, and my 3rd beta is tomorrow. I keep feeling like my ovaries are heavy. Kind of like how I felt just before a retrieval. Is this normal in early pregnancy? And yes, fallopian warrior, it is. Pregnancy feels like you're about to have your period anytime now. You get this really low back pain as well. And it's is it coming? Is it coming? And it's not, because you're pregnant. So that is really common. Next question here. Let's find it. How important is Medrol and doxycycline in a FET? It actually isn't. They're totally optional. A lot of doctors just do it out of habit. I do it out of habit. I think it might help some people, but some people get really bad reactions. So I always say, if you take Medrol, you get a big red face, swelling, facial flushing. If you pee all the time and can't handle it, if you get really jittery and have insomnia, stop it. It's not for you. Same thing with doxycycline. If you feel like you're going to throw up, if you're really prone to yeast infections, please don't even try it. Don't take it. Next question: is it okay to prime with HGH during the first period you get after a miscarriage, or skip the first to regulate the cycle, prime next, and then stim? I would just prime with that first period, and then you can stim and take it with your next cycle too. When should omnitrope be started for stim prime, and for how long, please? I started the month before, twice a week until the stim start, and then every other day. Next question is from Simran. Hello, I'm using an egg donor. Would you recommend the donor's blood group and my blood group match? Thank you. No, I actually don't recommend blood group matching. A lot of people do blood group matching for one reason, and that's because they think that they can get away with never telling their offspring that they were donor conceived. I got some news for you. You can have the same blood type as your donor, and you can't hide it with all these, consumer direct commercial tests looking at DNA like Ancestry and 23andMe. You can imagine at some point someone's going to give your child a Christmas gift, It could be when they're 50 years old to look at their ancestry. And then now your child's going to feel like you told them and kept from them some sort of secret. So there's a difference between privacy and secrecy. And for those of you who don't know Jana Rupnow, Rupnow, get her book, 3 Makes a Baby. It's a fabulous book. I love what she says on Instagram. She has a wonderful podcast, and I think she's awesome. Next question is from Naseem. Aw, you and your team are the best. Thanks for doing all you do for us. Thank you so much. Next question is, my second COVID vaccine is due on the day before my transfer. Would you wait to do it, or is it the day before okay? I don't want patients doing it that soon, and I'll tell you why. I worry that especially if you're taking progesterone and oil, that stuff is like almost a foreign body. That stuff is just wrong. I tell you, like the golf balls that I'm like pushing in on people's butts every day, I have patient after patients like, can you look at my golf ball? Can you look at my golf ball? And then you guys probably heard of that reaction that it was on the news the other day. But I know people say stuff on the news just to get attention. It was the Moderna vaccine, and people who had fillers in their face. Clearly, I need fillers, but I don't have them. People who have actually, I don't need fillers. I don't want fillers. So people who have fillers in their face, they said that they actually had a worse reaction to the vaccine. And I'm like, okay, well, that's interesting, because progesterone and oil is almost like a filler. I mean, it's like a foreign thing in your butt, and it lasts there forever. And some people can feel the bumps even like months later. So that's my thing about not transferring so soon after the second shot, especially. So if you were a patient of mine, I mean, not to interfere with your goals, like do whatever your doctor says, like don't listen to me. But that's like the one thing I'm like, I wonder if that vaccine will cause a reaction in people who are on progesterone and oil. So stay tuned for more. Next question is, what would be the success rate if the egg donor is 32? So, Anna, that's a great question. It really just depends on the viability of the embryo. And I don't know if you genetically tested or not, but a 32-year-old embryo that's beautiful has a really high chance of working, over 60% at least. Next question is, I'm 5 weeks pregnant after an FET, felt implantation cramps on my right side, and have infrequently been feeling a cramp in the same location. Slight spotting infrequently, sign that the embryo implanted outside the uterus, and I would say no. Sometimes our uterus is kind of like tilted to one side or the other, and you kind of feel a little pain there. And the other thing, it could be gas pain too. If you have spotting though, spotting can cause the uterus to cramp. And that cramping could be what you're feeling too from the irritation of the blood. So my rules about spotting, especially after a transfer, get your progesterone checked, make sure you're on enough, look and see if you're on any blood thinners, maybe consider stopping them, talk to your doctor, see what they recommend. Next question is IVF the best option with DOR if there's no other issue with male factor or otherwise? Age 40. It really depends on how you got to that diagnosis of DOR. I mean, basically every woman at 40, it's really hard to find a good egg for us if we're over 40, if you've crossed that. I mean, even over the age of 37, it's hard, but especially over 40. And an egg donor is always going to give you the highest chance of pregnancy. But the question is, are you ready for that? Are you ready to use an egg donor, or do you feel like you still want to try with your own DNA first? So that's just really a personal question. Next question is, which egg donor agencies do you normally recommend to your patients? Are there international agencies you recommend if patients were hoping for certain ethnicities? Okay, Ren. So the answer is, I really love recommending tulipfertility.com. They're kind of like the kayak for those of you who don't. It's like the Expedia, the kayak for all egg donor agencies. They're great. My other favorite agencies are Nationwide Egg Donor Agency. I love Happy Beginnings. I love My Golden Egg. MyDonorCycle.com. Not My Golden Egg, but goldenegg.com. For Asian egg donors, I like Asian Egg Donation. They're my faves. And then I think that's it for like fresh agencies, but I've worked with so many over the years. I mean, there's thousands of agencies out there, but Tulip has just made life so much easier for my patients using a fresh egg donor. Next question is from Katya. Does estrogen for embryo transfer and pregnancy in general increase copper levels, and by how much? Ooh, that's a good question, Katya. I don't know the answer to that, so I'm not going to answer something that I don't feel like I'm an expert in. Next question is, let's talk DHEA. If total testosterone comes back elevated as well as DHEAS, but free T is normal, should the dose be cut back? And it really just depends on how high is your total T elevated, and are you having any side effects from it? If the free T is normal, we really don't know what's normal for women. So you really have to know where is it in that normal range. So if it's like 3.5 or 3.9, I'm thinking at some point you're going to start to feel symptomatic. And I would, if you were a patient of mine, stop it. I'm just not the biggest fan of it. Next question is, what do you recommend once pregnant for TSH for people with Hashimoto's? I'm 14 days post-FET pregnant, yay, and my TSH is 0.6. My RE is recommending to just continue the current dose. Team infertility, I agree. Same, current dose. Next question. Hi, Dr. Aimee. I'm on my next mini stim and my follicles don't seem to be growing. 5 follicles at 3 millimeters. While I do have a history of longer stems, I typically respond. My FSH is 36, estradiol is 31. Mila, your ovaries are saying, leave me alone. They're saying, not this month. They're also saying, I'm taking a break. So listen to them and just stop. These things happen. It doesn't mean your ovaries are taking a little snooze forever, but it could be. When your FSH is 36, you're close to that range where your ovaries might be taking a break and it might be a little bit more permanent. So look at your AMH. I imagine your AMH might be in the like 0.05 to 0.01 range, but see what other things that you might consider doing. I don't know how old you are, but some of the strategies that I use maybe be like a whiff of estrogen, see if we can get the FSH down, look at anti-ovarian, anti-adrenal, anti-thyroid antibodies for you, and see if there's a role here for trying some sort of autoimmune protocol to kind of help with that. So there are lots of things, lots of creative ways that your doctor might be able to handle this situation, but stimulating when the ovaries aren't growing eggs just tells me your ovaries are saying, lay off right now and leave me alone. And it doesn't mean you have to wait for another cycle. Guess what? Show up next week. Literally. Like, do another FSH in a week. See where you're at. Excuse me. That cough came out of nowhere. This is what happens when you talk for so long. Okay, next question. My doctor gave me a prescription for HCG 10,000 units. But my insurance covered Ovidrel or Pregnil. What are your thoughts? Okay, Pregnil is the same thing. No big deal. Ovidrel has about 6,500 units of HCG. Okay, so just go Pregnil. Lupron is covered too, so yay. Next question is, let's see here. When are you going to share your levels since taking supplements? I will soon. Please repeat those supplements again. So NAD's True Nitrogen, Pterostilbene, PTEROS, Hi, and CoQ10. Hi, Dr. Aimee. I'm 34, AMH 0.2, diagnosed with DOR. Can't think of anything that would cause it except parents and sister have autoimmune disease. Should I get checked for anti-ovarian antibodies? And the answer is yes. I would do Fragile X, chromosome analysis, anti-ovarian, anti-adrenal, and anti-thyroid. Consider working with someone who will think outside of the box. There are a lot of us out there, and as you know, I am one of them. Over the past 6 months, my cycles have varied anywhere from let's see here. Over the past 6 months, my cycles have varied anywhere from 31 to 38 days. I'm always able to detect an LHP. Does this mean my cycles are regular enough to do a natural start for IUI or IVF? And the answer is, yeah, totally. Next question is, Hi, Dr. Aimee. I'm currently taking 4 milligrams of estrogen for the last 12 days. 2 of my follicles are larger than the other 4. Should I postpone the mini IVF? So it sounds like you're probably priming. And if 2 of your follicles are larger than the other 4, I'm not sure if you've started stim yet, and it's hard for me to say if you should postpone. I would kill for 9 mature eggs. I know, I'm telling you. Do you recommend Omnitrope a month before? And the answer is typically yes, 2 to 4 weeks before. Let's see here. Someone's saying, to the most sweet, my fertility appointment's in March. Can I ask my OBGYN to take care of my fibroids and all other preparation and sperm dating fragmentation before the fertility appointment? And the answer is yes. So I do send people the link for the sperm DNA fragmentation test. You don't need a doctor's order. You can do it without a doctor's referral. As far as the fibroids, you can definitely talk to your OBGYN about that. Get a formal ultrasound, look inside the cavity, see if the fibroids are there. Talk to your doctor about scheduling you for a hysteroscopy. That would be, a good use of your time. I personally think if there's an OBGYN that knows what they're doing, and a lot of them do, removing fibroids is quite straightforward for an OBGYN. That might be something that you get planned with your OB, but the fertility doctor can kind of guide you on the timing of it. Next question is, what is the risk of miscarriage for someone who's had PCOS that went in for an early ultrasound at 6 weeks and 3 days and everything was measuring great and saw a heartbeat of 122, one previous miscarriage? And the answer is, I don't know your age, Haley. But let's just say you're under the age of 35, having a heartbeat at 6 weeks, 3 days, I would say you probably have a 90% chance of taking a baby home. Once you get past 9 weeks, I would probably say you have probably closer to 97%. There's a cool test called the NIPT test that you can get done at 9 weeks, and that tells you more about the genetics of the pregnancy without doing something that's invasive. Next question is, I just did a Receptiva DX test and I got a BCL6 of 1.2. Great. I have severe menstrual cramps and always assumed I have endometriosis. The answer is you actually could still have endometriosis. So don't rely on just that test. So if you have all the signs and symptoms of endometriosis, the test could actually have not picked it up. So go with your gut, go with your ovaries, go with your uterus, and make sure you're advocating for yourself. And then you say, you know what, it just makes sense for us to look into this a little bit more. Maybe still do a laparoscopy if the pain's pretty severe, or maybe treating you in your transfer protocol as if you have endo. Next question is, can you repeat the name of the test to check and see if you and your spouse are genetically compatible to make a baby? Absolutely, Simran. It's HLA, all caps, KIR, all caps. Next question, and I use the company ReproSource to do that testing. I have the kits here, send it off. It takes about 3 weeks to get results back. It feels like forever. I have a 40-day cycle and potentially high prolactin levels. What should I do next? So I would treat the prolactin, check the TSH, take medications to bring down your prolactin level, do all the other fertility checks, and then see if your doctor would consider supplementing your cycles if you want to continue to try naturally with progesterone. Let's see here. Someone's saying, if someone is on Fragmin, that's basically a blood thinner, and developed a subchorionic hemorrhage, would you stop or stay on it and aspirin if they're MTHFR and PI1 4G carrier? And the answer is I would still stop it. I would probably stay on the aspirin but stop the Fragmin. Oh, yes. Someone, I just told you guys a story about someone on with a low count, and they asked, is he on Propecia possibly? Yes. So some men hide Propecia in the pockets of their bath towels and don't tell their wives because they're worried that their wives are going to think that they're not as manly for some reason. And that can affect sperm. I haven't had a cycle in 6 months after coming off birth control pills. Is that normal? I've tried Provera twice now, trying to see if that will help me jumpstart it, trying to get pregnant. And the answer is no, that's totally not normal. There's no such thing as post-pill amenorrhea. So if you haven't had your period 6 months after your birth control pills, get worked up for hypothalamic amenorrhea, PCOS, and decreased ovarian reserve. And also look at other hormones like TSH and prolactin. Next question is, I'm 28 years old. How much testosterone is too much when taking DHEA? My doctor's had me on it for 6 months, and I just had my FSH test, and it was 150. I'm 28. You're amazing. Okay, Erin, let's do all the genetic stuff, right? Like antithyroid antibodies, anti-ovarian, anti-adrenal, chromosome analysis, carrier screen. This stuff isn't hard. It's just those 5 things, okay? There's a great doctor. I love him. He's like so fun, and he's so great and so creative. And he runs a clinic. I think it's Ovarian Rejuvenation Clinic. Dr. Zahir Merhi, Merhi. You might be a good candidate for something called PRP injection into your ovaries. I don't know how well it will work for you, but it's something that you might want to explore. And I would say if your testosterone is really, really high, then maybe stop it, because obviously it might not be helping. But if you were a patient of mine, I would get you on all my supplements, like the True Niagen. I would start you on HGH, and then I would start giving you a whiff of estrogen. And I would start tracking your FSH. I would check it once a week, and then I would start going up on the estrogen to see if I can get the FSH to go down. And as soon as I get it to go down below 30, I'm going to be like, okay, let's see if I can get your ovaries to start making an egg. And sometimes it will work. And I've had it work on patients who have FSH levels as high as 150 before. I couldn't believe it when I saw it, and I still can't believe that I've seen it, but I have seen it, and I've retrieved an egg, and I've made an embryo. I haven't used the embryo yet. I'm still trying to make more. So next question is, currently going through an ectopic, I'm sorry about that, from a natural pregnancy. This will be my 4th natural miscarriage. Do ectopics can signal endometriosis? I have a high Receptiva DX score, and I failed 2 IVFs. So the answer is actually the Receptiva DX score can be a sign that you might have a tubal issue, a hydrosalpinx, and that can cause an ectopic pregnancy. So in a case like yours, I wouldn't try and manage this ectopic medically. I would say, if you're comfortable with that, consider surgical management, do IVF, create embryos, and then maybe do surgery to take a look at the tubes, and you might not need them. It doesn't seem like they might be actually getting in the way. Not both. You may not have to remove both, but at least one. Next question is, can high prolactin lead to infertility, and can this be resolved after DOS-nest? The answer is yes. Is there a chance for this to be resolved once levels are lower? Absolutely. Hyperprolactinemia is not an uncommon reason for fertility issues. Could a low hemoglobin impact pregnancy? Thalassemia carrier, so hemoglobin is always lower than average. No, so in general, if it's a genetic form, it doesn't harm pregnancy. This next question, I had 2 failed IUI cycles, and then found out I had a polyp, had a hysteroscopy to get them removed, and then had another failed IUI. Should I think of the first 2 as pointless? Is that I really only did 1? And the answer is, Daniela, Yeah, I mean, just depends on how big they are. So if they're teeny tiny micropolyps, I'm not sure how much of a difference they make. But if it's a big fat polyp, like sitting in the middle top of your fundus, then yeah, it could really affect implantation. And I've definitely had cases where I just remove the polyp and the patient gets pregnant. But I also have cases where I remove the polyp and it comes back. So if you're someone who makes recurrent polyps, you might be a person that says, you know what? If this keeps happening to me, I'm thinking like every time I stimulate with these hormones to get to IUI, that might be detrimental to like your goals of having a healthy implantation. So you might want to just say, look, I'm going to stop removing polyps. I'm just going to go right into IVF, make embryos, then remove the polyp and transfer. My husband and I have been trying to conceive for 7 years now. My OB has tested me for, it looks like endometriosis. And I'm trying to see where the rest, my husband, okay. My OB checked for endometriosis. Would you recommend the next step be that we should take? Okay, so next step, just go to tushimethod.com, get all the tushy stuff checked, go to a fertility doctor, talk to them about what your goals are, your diagnosis, the prognosis, and what the treatment plan should be to address your diagnosis and help you reach your goals. I know I make it sound easy. It's not as easy as I make it sound, but that strategy is really easy to think through. It's really easy to think about. You can write it all down. Go into your doctor with the questions that you have so that you can get it all done. Okay, when using a sperm donor, is a younger donor better, like someone in their early 20s? No, not so much. I know I wouldn't necessarily use a sperm donor that's in his 40s, but I think a sperm donor in his 30s is good too. Next question from Christina. First round of IVF ICSI, 5 fertilized, all arrested. I'm sorry. Second round of IVF, 6 retrieved, 4 blasts. I have 3 transfers with 4 embryos and none took. I have 1 embryo left. What do you suggest next? Christina, if you haven't done genetic testing, I would do that. And then definitely before you do another transfer, do implantation testing. If you don't feel like doing chromosome testing on your embryos, no big deal. Do chromosome testing on you and the sperm source. And that's kind of what I would do. Next question is this. My HCG was 544, 12 days post-transfer. Am I out of the woods for an ectopic pregnancy? Doc didn't order a second beta, but I'm scheduled for a week 5 scan next week. So the answer is every pregnancy is assumed by a fertility doctor to be an ectopic until we see it in the uterus. So the likelihood of an ectopic with a really good HCG level is lower than if it was like, not so good. But still, that's not like a discriminator between ectopic versus not. So the best thing to do is exactly what your doctor is doing, is look. And I think that's a great thing that they're doing a 5-week scan for you. After my second round of IVF in January, if it's unsuccessful and we can't afford more rounds, should I keep doing IUIs? And it just depends on your age, right? So it's like, how old are you? What are the chances at your age? That's what I would talk to your doctor about. And then you'll see, does it make sense to do more IUIs? Or should you start talking about other awesome family building options that are out there? Alda is saying, natural FET, what's the latest cycle day for ovulation to still be okay for transfer? There really isn't a latest cycle day to be okay for transfer, but I don't do natural cycle FETs for people who have really long cycles. The only time I'll be like, yes, you're a good candidate for a natural cycle FET is if we have a beautiful 28 to 32 day cycle where ovulation is really predictable. It makes sense to do a natural cycle FET in that situation. Otherwise, it doesn't make sense to me. Someone is saying, I did an ERA before with injected progesterone. I was receptive. For this cycle of IVF, I got 3 chromosomally normal embryos, did hysteroscopy. My doctor thinks I'm fine without the ERA for the FET. What do you think? I agree. I don't think you need to, I would say that your doctor probably is on to something. You probably don't have to put yourself through that again. How soon after the FET can I take a home test? I mean, you could check and detect a positive pregnancy test even 4 days after a 5-day transfer. I don't recommend doing that. I check all my patients 8 days post 5-day transfer. A lot of them do pregnancy tests starting at 6 days and they tell me that it's positive. But I've also had patients who do a test 6 days post 5-day transfer, have a negative day 7, even have a negative day 8, and sure enough, they're pregnant. Next question. I'm 45 years old. My current stats are AFC is 30. Holy smokes. AMH is 11.78. Who are you? Are you sure you're 45? FSH is 7.6. BMI is 22. I have a 3-year-old boy from an IVF with ICSI. Karen, go do IVF again, because I would love for you to be a 45-year-old that's successful, and then I can talk about how I knew someone once who was 45 who had a successful pregnancy. Based on stats, what would you suggest going forward for another IVF cycle protocol? How many eggs would you say I'd be likely to get? I mean, you're probably going to get at least 15 to 20 eggs from an IVF cycle, but the issue is this. It's not like 1 out of 10 is going to be genetically normal. The hardest part of being 45 still is just being 45, even if you have the eggs of a 25-year-old. The reality is you still have the eggs of a 45-year-old. You just have the numbers of a 25-year-old, and that's pretty awesome. So if there's ever a 45-year-old who can do this with their own eggs, it's probably you. But I've been here before with women just like this. And I've worked so hard, done so many cycles with this number of eggs, and I'm still not able to overcome the age thing. It's just really hard to find a good egg at 45, and it might not be there. But the fact that you have a 3-year-old, hopefully that means your eggs still got it. Okay, next question. If I had a retrieval and got my embryos PGS tested and 4 were normal, all of which are boys, what are the chances of having a girl if I do another ER? Egg retrieval. So I would say this: you have to tell your husband that he has to wear pink every single day. The sperm has a 3-month life cycle. He has to wear pink every single day, like decked out pink hat, pink turtleneck, pink socks, and then maybe you'll have a girl. No, that's totally not true. There's really nothing you can do to turn an embryo that's in your control into a girl or a boy. It's just literally flip of a coin. That's it. There's no amount of pink that he's going to wear. There's no amount of I don't know what that's pink that he can do to turn an embryo into a girl. There just isn't. So just talk to his sperm. Make him wear a headband. Could a dermoid cyst interfere with ovulation? Ultrasounds every 6 months show it's stable and unchanging. Gynecologist doesn't seem concerned. So my thing is this, like, think of little ovaries, right? You got a dermoid. Oh, it's like pulling down on the ovary, right? Depending on how big it is. That could be affecting egg pickup on that side, right? I mean, how is that egg supposed to find a freaking fallopian tube, right? It's like this little microscopic egg, and it has this like big dermoid like in front of it. And it's like trying to go over the dermoid to get into the fallopian tube. So whenever I see something like that, I'm always saying, the dermoid doesn't cause fertility issues, but there could be some sort of mass effect where egg pickup might not be as efficient. So there. Hope that helps. Next question is, I'm on my 4th IVF cycle and taking DHEA, CoQ10, royal jelly, folic acid, and also doing LIT, where the white cells of my hubby are injected into me. What are the chances of getting good eggs? I don't know how old you are, and it's hard for me to say, but I would hope that there's still a good chance. I mean, I'm looking at your profile picture. You look like there's a good chance. I'm kidding. As if like I could be like, you look like you're going to get pregnant. Oh, God, wouldn't that be easy? Just take a photo of yourself, send it to me, and I'll tell you. Early pregnancy and using Cronone. Should I insert the applicator halfway in or all the way in? So there's the finger test here. I'm going to show you the finger test. Let me see. Pretend like this is your Cronone applicator here. Finger test. I have man hands, very big fingers. So for me, I'm going to insert the Cronone applicator up to here. Okay? That's how far it goes in. Next question is this. Hi, I was 39 or 40 at the time of the egg retrieval. I was told that I have 1 expanded blast fair and 1 expanded blast good. Embryos are not tested. Not sure what your thoughts are. I would put both in. That's what I would do if it were me. I would also probably do more cycles too, because I would want you to have more kids if that's what you want to. Next question is age 30, first transfer miscarried with low heartbeat, normal embryo, did entire workup, only answer was MTHFR and PI1, transferring again soon, so nervous. What are the chances? The chances are still good. I would make sure you've done the ERA. Not so much the ERA in this case, but look at protocols that can address endometriosis. Look at the cavity very closely, and I bet your doctors, since they did that testing for PI1, they're probably recommending a blood thinner. Next question. I'm 41 now and have had 2 IVF cycles, 1 embryo one time, and second time, both times with Clomid, still abnormal. Is there any hope for me? And the answer is there is still hope. There's nothing wrong with you. It's just age related. There's nothing you can do. You're doing everything that's in your control. So just keep trying and then be like, look, if by March I'm not pregnant yet, we're going to move on. We're going to talk about other options because this is for the birds. Okay. How should an LGBTQ couple approach reciprocal IVF from the start? Ooh, I love that. Let me see if I can do that in 30 seconds or less. Step 1, make sure your doctor knows this question. The answer to this question. If they don't ask you, make sure you tell them, hi, doctor, this is what I would like you to know about what I want our family to look like in the next 5 years. Be very specific. Eggs are coming from which maternal source, uterus, etc., right? Describe it to the T, okay? You can't have your doctor might have assumptions about what you want that are totally incorrect. And I've done it all, literally. I've used sperm from a dad into one wife and then a different sperm source. So you want to make sure that you are expressing exactly what you want to your doctor, and then they'll make it happen. Be like, doctor, be my project baby maker. And this is what we want. But you can't assume that your doctor is going to know what you want without saying it. So that's probably the most important tip that I can give you in 30 seconds or less. Next question. I just turned 36. I have low AMH. Only one ovary due to torsion. Planning for egg retrieval and fresh transfer next month. I had decided not to do PGS since I won't get many embryos. Right decision or not? This is the thing. I would say, why did you have torsion? Usually you torse an ovary because there's a cyst. What was in that cyst? Was that cyst endometriosis maybe? So make sure you've looked at that and ask your doctor if there is endometriosis, if you need treatment before you transfer. So maybe you don't need to do PGS testing, but maybe freeze the embryos, look for endometriosis, and then transfer so you don't look back and be like, why didn't I do that? So I totally get the desire to want to transfer fresh. Could taking 500 milligrams of naproxen stop ovulation? I really don't think so. I know there's some studies out there that say that it does, but I don't really think so. Dr. Aimee, I'm 7 days post 3-day transfer. I have no symptoms. Can I still be pregnant? And the answer is yes. 7 days is still really early. Most patients don't know at all if they could be pregnant. Next question. I've been putting the current on all the way since transfer. Could I have hurt the baby? And the answer is no. There's no way you could have hurt the baby. Also curious, do fertility doctors find it helpful or annoying to receive regular yearly modern fertility hormone tests? Reagan, no, I have eggwhisperer.com. I am the original modern fertility. I've been doing level checks for patients since I started my practice, and I started that website for that very reason. I want women to track and trend their levels, get all the fertility data points that will guide them to kind of lay things out for their roadmap for fertility success. So I don't think it's annoying. And if a doctor thinks it's annoying, I would say, I can't imagine that there's going to be a fertility doctor that says it's annoying. I really don't. Is it normal for menstrual cycle bleeding to lessen after using fertility medication? And the answer is yes. It is very possible that your period might be a little bit shorter and lighter after you take fertility hormones if you weren't pregnant. Because of what? An ovarian cyst. Ovarian cysts that secrete estrogen can decrease your menstrual flow. So if that happens, you should tell your doctor. Let's see here. Last question. I don't see a question. You guys have just been so awesome tonight. It's really fun to hang out and answer your questions. And thanks for putting up with all my not so funny jokes. You know, I'm trying to be funny like Amy Schumer. I tried to get a show once and I got so close. And they said, you're just not as funny as Amy Schumer. I'm like, sorry, I can't fake that. So have a great night, you guys, and I'll be back next week. Have a happy end of the week. Happy New Year. Do something fun. Do something really, really fun. I don't know what that could be. I don't know. What am I going to do? Probably work more and help more people have babies. I can literally not think of anything more fun than that. Okay, guys. Peace out. Have a great night, and I'll see you guys later. Bye-bye.